Can paquimetry data alone accurately diagnose keratoconus? A fresh look at corneal thickness progression. Introducing the Thickness Speed Progression Index (TSPI) on the Galilei platform. This is Shady Awwad from the American University of Breve. Corneal imaging has made great strides over the past 40 years, and the start of the innovative streaks was the introduction of computerized color-coded topography, transitioning from simple keratoscopy, and this was made possible by Stephen Kleiss in the early 80s. Stephen Kleiss is considered the father of modern corneal topography. All the work on AI could not have been possible without this critical transition. Now, more importantly, however, Kleiss also pioneered early work in AI and corneal topography with a study published in 1997 using neural network to improve the detection of keratoconus on the TMS-1 topographer. Kleiss experimented with neural networks for a few years, but it wasn't until 2012 that Francesco Versace with Maria Clara Arbelaiz used support vector machine on the series Scheimpflug tomography to differentiate keratoconus from normal and suspects. This was followed by Bernardo Lopez, who published the Pentacam Random Forest Index using 17 parameters derived from the Pentacam Scheimpflug tomography. Then Renato Ambrosio integrated Pentacam Scheimpflug tomography with biomechanical data from the Corvus ST. Ambrosio later published the TBI version 2, a multicenter study with 551 very asymmetrical ectasia normal, and also using random forest decision tree algorithm improved the sensitivity of the model for KC suspect detection from 76% for the TBI 1 to 84% for the TBI 2, with the same specificity of 90%. Then Francesco Versace with Jorge Alio del Barrio and colleagues used artificial neural network on Placido and OCT data, including epithelial profiles, on the MS-39 platform. Now, with improving AI methodology, the rate limiting step truly becomes the quality of the parameters used to train the model. But many of these parameters used to train these complex black box algorithms are based on some basic formulas laid out more than 30 years ago and which are sometimes considered rudimentary by the computing standards of today. This includes the KISA score, the IS value, and the corneal thickness progression metrics, among others. Now, thickness progression is an interesting parameter, as a recent paper by Cynthia Roberts published in Ophthalmology Science shows that early changes due to strain in normal susceptible eyes start with focal thinning, which leads to redistribution of stress, which leads to increased focal curvature, which in turn leads to redistribution of stress, and this leads again to increased strain and focal thinning. And the cycle goes on, so often early ectatic changes might sometimes be noticed by change in thickness progression. Now, we are all familiar with paquimetry maps that were first displayed on the Pentacam device. Now, thickness progression metrics were first conceived by Renato Ambrosio, who believed firmly that keratoconus starts with a biomechanical weakness that first leads to redistribution of stromal fibers and therefore a corneal paquimetry profile change. Now, Renato came up with a paquimetry progression map centered on the thinnest point of the cornea, and he compared the values to the normal population. Now, indices such as the corneal thickness spatial profile, the percentage thickness increase, PTI, along with a bunch of other indices such as the minimum hemimeridian progression were all described. Now, all these paquimetry progression indices were weighed and reflected in the BADD index under DP. The corneal thickness spatial profile and the percentage thickness increase, however, perform an average of all points on average circumference centered on the thinnest point from 0 to 10 millimeter diameter, therefore producing the maps. Now, the issue is that this would lead to dilution of early localized changes, where a localized sudden increase in paquimetry would be diluted with other areas, especially the opposing areas, which might have a relatively slow paquimetry change. Additionally, averaging of the steepest and slowest hemimeridian, which is meant to be more sensitive in picking up localized changes, also suffers from dilution where there is an averaging of data points along the hemimeridian, diluting early focal changes with nearby data on the same hemimeridian. And more importantly, this methodology does not offer a comprehensive approach in analyzing the paquimetry maps and the relative relationships of different data points. Consider this eye, for instance. The thickness progression profile on the pentacam is normal. The paquimetry progression on the fellow eye, however, is highly abnormal and clearly indicates keratoconus. So is this a case of unilateral keratoconus, or is it a case of very early keratoconus in the fellow eye? And we are failing to make sense of the available data to diagnose it. Instead of looking at indices, let us go back to the raw data and take a closer look. This is the paquimetry map, and there is a fast progression in all meridians in the keratoconus eyes and mainly inferiorly. Now things are not as clear in the fellow eye, where it looks like it is normal. Now let us look at the thickness speed data relative to the thinnest point of the paquimetry map, and this is measured as the thickness at any given point minus the thickness at the thinnest point divided by the distance between them. It is easy to notice that this thickness speed is progressing fast the more you travel inferiorly on the cornea, as depicted by the green, yellow, salmon, and red color. Compare it with the opposite hemimeridian, which is very slow and colored in blue. Now compared with the traditional thickness progression maps, which fail to depict these focal intricacies. The reason why the traditional thickness progression maps fail to depict the focal intricacies is because they average data from all the meridians and therefore dilute the focal changes with the opposite and neighboring areas, which have slower changes. Now, how to transition from these subjective early observations to a clinical decision-making algorithm which is objective and based on the best combination of sensitivity, specificity, positive and negative predictive values? The best way is to first define objective parameters. We first define absolute thickness speed values at 1 millimeter to 4 millimeters diameter centered on the thinnest point. The algorithm will average data points along 15 degrees arc length at each diameter and would find the largest mean value for the absolute thickness speed, ATS, at 1, 2, and so forth. We then define differential thickness speed values at 1 millimeter, 2 millimeters to 4 millimeter diameter centered on the thinnest point. The algorithm averages data points along 15 degrees arc length at each diameter and would find the largest mean difference values between two opposing 15 degrees arc at 1, 2, and 4 millimeters. So the areas under the arc were computed for each parameter, and cutoff values were identified. Now we have 6 parameters which can be fed into a machine learning model to come up with an index, and this index is the thickness speed progression index. The study was recently published in AJO. Now the 6 parameters were fed into multiple machine learning algorithms, from logistic regression to support vector machine to AdaBoost and random forest, among other models. The best model was the random forest, yielding the thickness speed progression index. Now, when evaluated with a 3-way classification and looking at the confusion matrix, the model did very well for normal and keratoconus KC eyes and could diagnose 73% of KC suspects as either suspects or keratoconus. But more importantly, none of the KC eyes were labeled as normal, and none of the normal were labeled as KC. And again here, the model was 100% sensitive and 91% specific for normal eyes, and 98% sensitive and 100% specific for KC eyes. But again, more importantly, the model accurately classified 73% of suspect eyes as either suspect or keratoconus, with 99% specificity and 95% and 93% positive and negative predictive values. And when we compare with data from our previous articles on the Corvus and Pentacam, we notice that when evaluating KC suspect eyes classified with similar but not exactly same values, also using the Galilei and in addition the Pentacam, the sensitivity and specificity and positive and negative predictive values of the TBI 1.0 were similar to the thickness speed progression index, with the biomechanical indices like CBI SPA1 right behind. As we all know, keratoconus diagnosis necessitates multimodal imaging, and therefore the TSPI is an enhanced evaluation of thickness progression and can be used in addition to other parameters relating to curvature, elevation, and biomechanics to further improve the detection accuracy and the sensitivity and specificity in keratoconus and on suspect eyes, and therefore better screen laser vision correction candidates. So going back to our example, this is the worst eye of the same patient presented at the beginning, obviously showing keratoconus. The other eye looks normal by the thickness progression profile of the pentacam. Now this is the quad map of the pentacam showing some inferior steepening and slightly suspicious posterior elevation map. Looking at the Galilei quad map, we see the same inferior steepening on the anterior and posterior curvature, the elevated temporal area of the posterior best fit sphere. The CLMIX here is normal, which means this is not keratoconus yet. But the thickness speed progression profile on the Galilei shows clearly that this is a suspicious progression suggestive of a keratoconus suspect due to an increase in differential thickness speed progression at 4 millimeters, 2 millimeters, and 1 millimeter, albeit a normal absolute thickness speed TS4, 2, and 1 millimeter. And the final verdict is suspicious asymmetry when all 6 parameters are included into the final machine learning model. Interestingly, a corvus performed on this eye showed a low SPA1, a poor ARTH, and an abnormal CBI with borderline TBI despite a normal bad D. But above all, as we all know, garbage in, garbage out, bad measurements will lead to poor data acquisition and therefore poor algorithm verdicts. And for the TSPI, the most important to consider are the tear film and the eyelid positions. In this case, for instance, the tear film is pooling inferiorly. The Scheimpflug, just like often in OCT technologies, cannot differentiate between the tear film and the surface of the cornea, so it would assume the corneal thickness is thicker inferiorly due to the tear film pooling. This is the resultant quad map. You can see that there is an inferior posterior curvature steepening and the maximal change rate of the thickness speed looks large and the TSPI shows suspicious asymmetry. Now when we send back the patient for a better measurement, the eyelids are spread apart and no pooling can be seen inferiorly. The inferior steepening on the posterior curvature is not seen anymore and the maximal change rate of the thickness speed becomes normal. And the TSPI also shows now symmetrical speed progression, meaning it is normal. This is another example of poor acquisition with superior and inferior eyelids covering the cornea, also creating tip pooling inferiorly as well as superiorly. Here's another example. These measurements will for sure cause a completely changed tear film which will impact the corneal thickness distribution across the cornea and would affect the TSPI decision-making algorithm. Therefore, it is key to instruct the ophthalmic technician to take very good measurements with no tear film pooling and well-spread eyelids. The TSPI report allows you to directly visualize the infrared image to check the eyelid position and tear film pooling by right-clicking on this panel. You can also check the Placido-Myers to assess tear film quality, as this also has an impact on the thickness progression. So as a conclusion, the TSPI is an enhanced analysis algorithm for the paquimetry progression, purely based on paquimetry profile, but with a strong diagnostic ability to differentiate keratoconus from normal. It is, by the way, less dependent on fixation or on angle alpha. It is trained in a three-way model, KC, KCS, and normal. It can be used in multimodal imaging to further improve detection accuracy in keratoconus suspects and in better screening for laser vision correction candidates. This was the Thickness Speed Progression Index TSPI on the Galilei.